Hello and welcome to Project First Line, the mini-series podcast on infection prevention. The Arizona chapter of the American Academy of Pediatrics is proud to partner with the American Academy of Pediatrics and Centers for Disease Control and Prevention's Project First Line to bring you this podcast series. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, Professor Emeritus of Pediatrics at the University of Arizona College of Medicine, and long-term contributor to infectious diseases and immunizations topics at the Arizona chapter of the American Academy of Pediatrics. I do not have any financial relationships to disclose, and I have no interests with any ineligible companies. So this is session number 1 of the Project First Line mini-series. We'll be dealing with basically a primer on congenital syphilis, what it looks like, what the risks are, how we especially diagnose and treat it, and how we can prevent it. And I will say, as sort of an overarching comment on this, the best way to prevent this specific disease is to find and treat the mothers, which of course is a little bit outside the scope and purview of a pediatrician. However, we get to advocate with our colleagues in obstetrics and gynecology, and we certainly get to advocate at the public health level in all areas possible, regional, state, national, international, to try and increase screening practices. Congenital syphilis, as you can imagine, is a sentinel event. It is a completely preventable infection for babies if only we can find and diagnose all sexual partners contributing to maternal transmission to the baby. So let's start first by just sort of going over what is congenital syphilis, what is the risk, and as you can imagine, the risk is highest for those mothers who have had more recent disease. In fact, there's something known as Kasowitz's law, which states that the longer the interval is between infection and mom's pregnancy, the more benign the infant outcome. So those mothers who are in the very early stages of primary and secondary syphilis, of course, have a huge risk of transmitting syphilis, treponema pallidum, to their babies in utero, and for those babies to be born already actively infected with syphilitic disease, versus those mothers who have latent or early latent syphilitic disease, in whom the risk of transmission, while still quite present, may not drive an actively symptomatic baby. This is, I guess, perhaps better for baby in terms of overall outcomes initially, but it's dangerous because it means that easily those babies could be missed. And so too could the mothers be missed unless we practice routine screening practices. And in fact, maternal disease, unfortunately, in the setting of transmission to babies, is frequently silent. Contrast that to the fact that in any stage of illness, mom's risk of transmitting syphilis to her baby is anywhere from 70 to all the way to 100%. So this is a pretty major deal to be coping with, and especially in a setting where things are quite asymptomatic. So what does congenital syphilis look like in those babies who are actually symptomatic when born? Keeping in mind that easily 2/3 or more will be asymptomatic. But those babies with active signs and symptoms of syphilis will likely have some degree of hepatosplenomegaly and or a distended abdomen. They may have a desquamative skin rash, which looks very much like peeling skin, but especially from the palms and the soles. So think of that baby who's perhaps post-date. So they were maybe born at 41, 42 weeks estimated gestational age, and they just look crinkly, right? That sort of dry, crinkly skin. But if you accelerate that or escalate that into significant patches of skin desquamating from palms and soles, that is the picture of congenital syphilis. Not as visible, but babies may have long bone changes, and specifically, they'll have evidence of periostitis and osteitis. So one does long bone x-rays, we'll get to evaluation in just a second, but on that you can see very prominent periosteal signal, and even if things have progressed quite extensively, you can see what's known as Wimberger's sign, which is a linear hyperdense band across the terminal epiphyses of the long bones. So any radiologist will be quite familiar with what the osteitis and periostitis of congenital syphilis looks like on plain x-rays of the long bones. Babies may have what are known as snuffles. Now, distinguishing that from the sniffles, and yes, all of us have had the sniffles with the common cold, etc., and certainly babies as obligate nasal breathers are going to sound sniffly, right? That sort of congested nasal breathing. Snuffles of congenital syphilis, in contrast, is frequently hemorrhagic, and it is certainly mucopurulent. So think of this as the baby who has the unexpected, copious, purulent to bloody purulent discharge from their nares. That would be snuffles. Babies may certainly look jaundiced if they have syphilitic hepatitis. They may well have edema or even hydrops fetalis if they have nephrosis or nephrotic syndrome. Worst case scenario, they may have seizures, irritability, disorganized feeding if they have neurosyphilis causing meningoencephalitis. So that would be what babies will look like early on, certainly even in the delivery room and or perhaps recognized in the first 1 or 2 days of life. Fast forward then to those babies who don't have symptoms yet are infected and whom we fail to detect and prevent further escalation of disease. They can develop further stigmata of congenital syphilis, and these are known as the late findings. So something known as Hutchinson's triad, which includes an optic neuritis, a sensory neural hearing loss, and perhaps even uveitis with that optic neuritis, and then the long bone changes, and especially teeth changes. So Hutchinson's teeth, as part of the Hutchinson's triad, are 2 forms. One is notched incisors. The other are what are called mulberry molars. Now, you may not have grown up in a part of the world or the country in which mulberry trees exist, but think of the mulberry as sort of like a large walnut or sort of a large olive-like fruit that is rounded and smoothed. That would be ultimately the child's molars, or even adult molars if they're not picked up early. Themselves, instead of having the normal findings of a classic molar tooth, they'll look rounded and bulbous. You have to look at a picture of it to really sort of fix it in your head. But the notched incisors, I think, are the more easily visible, certainly in the anterior portion of the mouth, and will contribute significantly to that picking up the congenital syphilis. So classic Hutchinson's triad would be the teeth findings, conjunctivitis or uveitis, and sensory neural hearing loss. And then of those, the teeth are probably the most prominent. Other findings that you may find, there will be a bowing of the shins, which then would prompt hopefully plain x-ray and findings of sort of very organized osteitis and periosteitis. Patients may have frontal bossing. They may have the saddle nose deformity. So sort of think as the sort of scooped out saddle of a horse with which you ride a horse, and then apply that to the nasal bridge. And in fact, if you look at historic pictures and even paintings, portraits from the Renaissance period, especially of the nobles and kings and queens and all that, you'll see a fair number of those facial images that have a saddle nose deformity, because syphilis, A, was not recognized as syphilis, and B, of course, was fairly prevalent. So you had a whole bunch of young adults born with congenital syphilis who then developed the saddle nose deformity. The final 2 findings, which are maybe seen with late-stage congenital syphilis, are brigades. Think of these as sort of the fissure-like or fan-like fissures at the corners of the mouth. I grew up, in the 70s and 80s seeing all the pictures of smokers, and the faces. Think of the smoker's mouth, and you have the picture of brigades. And then Clinton's joints, which are swollen joints, is a hydroarthrosis, so collection of water, especially seen around the knees. So you might be able to have a bilateral patella, and certainly the joint itself will feel squishy, just like there's fluid retained in there. Think of the traumatic knee, which has then been leaking fluid. So those are the findings then of late-stage congenital syphilis, and I share those with you in large part because we may have children who have been born into an underserved area or not picked up at birth who may enter our practices and have these findings, and that should definitely drive the evaluation. So what is the evaluation, and what is the protocol, the algorithm to assess the mother-baby dyad at birth or shortly after birth to identify that person whom we need to do further testing and potentially treatment? So first and foremost is a critical, and I do mean critical, need to screen mother at several points in her pregnancy. In certainly some parts of Arizona, Maricopa County with Phoenix, the protocol is appropriately very conservative and very appropriate. So mother is screened at her point of entry into prenatal care, whatever that may be. She is screened again in her 3rd trimester, and she is screened again at time of delivery. So that's 3 screenings. Now, what the screening looks like may be changing. In fact, as you listen to this webinar, it may have already changed in your local practice area. Historically, screening was with a non-treponemal antibody test, the RPR, which I assume and think is probably familiar to most of us. Increasingly, however, hospitals are doing what's called a reverse sequence screening approach, in which they have a rapid, even a point of care, screening test for a treponemal specific antibody. So again, in historic terms, when we used to do the RPR screen, a reactive or a positive RPR would automatically reflex then doing a treponemal specific test, such as the FTA absorbed, the fluorescent treponemal antibody absorbed, or the treponemal pallidum absorbed test, because those IgG tests were specific for the causative agent of syphilis. The RPR, being non-treponemal, is very sensitive, but it is not 100% specific, and certainly there's a whole long list of causes of false positive RPRs, not least of which is the state of pregnancy. Great. So that would mean that those low titer positives that moms may have, 1-to-1, 1-to-2 dilution, could actually be a false positive of pregnancy. Certainly mothers who had antiphospholipid syndrome, those with anti-cardiolipin antibody, those on some medications could have even higher false positive RPRs. So while it's an important and a very effective screening tool, it is not that specific, and it means that we would need to do further testing to confirm that the RPR on mom truly meant syphilis. In the newly emerging reverse sequence screening approach, the treponemal specific antibody is both sensitive and specific, and it will detect every mother who has had syphilis at any point in her life, because that IgG will persist, with very, very, very rare exceptions, will persist for the life of the human being. Now, here again, perhaps it's a bit too sensitive and a bit too specific because it only tells us that mother has had syphilis. It does not tell us if she was treated effectively, or how long ago she was treated, or how recently she may have been infected, except perhaps in, at least 1 or 2 weeks before doing the test. So in the algorithm, and if you really would like to try and test the accuracy of your glasses and your magnifying glass, go ahead and look at the figure in the Red Book if you have one in your practice or at hand. And it is well laid out there, but somewhat difficult to follow, I think, to many. And that's not in any way a slam against the organizers of the Red Book, heavens no, because I've been part of that as well, but just that it gets a little bit confusing sometimes. So if we have a mother who has a positive RPR, as we are then waiting for the reflex treponemal antibody test to confirm that that's a true RPR, we're waiting for the titer response, how high is it, and we need to be asking mother, does she have a known history of syphilis? If so, was it treated? When was it treated? How was it treated? So for mothers who have syphilis, so actively pregnant, they will require at least 2 and sometimes 3 weekly doses of an injected long-acting benzathine penicillin. If they have not received that, or if they completed the last dose of their penicillin treatment within 30 days of delivery, then they would be considered not adequately treated, and baby has a true risk of infection, and thus we do everything for the baby. If, however, mom has a history of syphilis, we'll say several years before pregnancy, was treated effectively then, and has had negative RPRs since that time, but now has a positive RPR, well, guess what? There's a potential possibility that she may have been reinfected. And of course, it's not just moms, it takes 2 to tango. So father or baby also is a potential source of this disease. So that's the general initial response to a positive RPR. In the setting of the reverse sequence approach, where we have a screening treponemal antibody, that's positive. It will reflex to an RPR. So now we're looking to see how active potentially the disease is. We're still going to mother to ask about her history. So long story short, a lot of the initial evaluation depends on mom's history, what her initial screening tests are, and then ultimately we'll be testing baby as well. So if we look then, and the easiest answer to all this is both mother and baby have negative RPRs and or negative treponemal antibodies, then we're done. There's no syphilis, nothing to worry about, everything's fine, go about your happy way. In the setting where mother and baby have a positive RPR, but mother has a negative treponemal antibody, that's a false positive RPR from mother, and of course maternal IgG crosses the placenta, so she's transferred that to baby. That is also not syphilis. It's a false positive RPR. In the case where everything's positive, both mom and baby's RPR and treponema antibodies are positive, and we don't yet know mother's disease, we have to consider that as a possible transmission. Now we absolutely need to know if mom was treated, when and how, and was she treated effectively. And then the final category is mother and baby have a negative RPR, but mother's treponema antibody is positive. That would mean that she was treated successfully, and we typically don't need to worry about the consequences. So in the setting where there is a risk of infection for baby, so mom is positive, baby is positive, mom was not treated and or was treated inadequately, meaning not completing therapy prior to delivery, 30 days prior to delivery, or only getting, for example, 1 dose of penicillin, then we need to evaluate and treat baby. And this is going to be the important component of this. What does that evaluation look like? First of all, it needs to occur in hospital because that baby at the minimum is going to be getting 10 days of intravenous penicillin G treatment. So how do we evaluate? Well, we need, of course, baby's RPR. And what we're looking for in that case, even if we already know that baby was infected or exposed to untreated or undertreated mom's syphilis, if baby's RPR is 4-fold higher than mom's RPR, that means baby already has their own active syphilitic disease, not just transplacental transfer of maternal IgG. So therefore, we're already going to be treating for at least 10 days, perhaps even longer. So we need baby's RPR. We'll certainly wish to see what a complete blood count looks like in terms of pancytopenia, thrombocytopenia. We need to do a liver assessment, typically a comprehensive metabolic panel or a hepatic panel, wanting to look and see what the transaminases are, so the AST and the ALT, and then also the bilirubin, albumin, total protein, just to look at synthetic function of the liver. We'll need the long bone x-rays, and in fact you can order those on pretty much any EHR that we have as long bone radiography or long bone x-rays. Baby does need a lumbar puncture. We need to be sending the CSF for a VDRL. And if any of the above are positive, then many would also do an ophthalmologic evaluation, a dilated slit lamp exam, looking for evidence of the retinitis, the keratitis, etc. I guess I should say, just because, if there's one sexually transmitted infection, there may be others. We should also be paying attention to mother's HIV status, as well as other things like gonorrhea and chlamydia. So the treatment then, babies infected, meaning they were exposed to under or untreated maternal syphilis, regardless of whether any of the aforementioned testings were positive, baby's already going to be getting 10 days of intravenous penicillin G, 50,000 units per kilogram per dose given every 12 hours for the first 7 days of life, and then increase the frequency to every 8 hours to complete the treatment. If baby has proven disease and certainly has central nervous system disease, meaning that CSF VDRL is reactive, then they deserve 14 days. If they're symptomatic with the neurosyphilis, meaning seizures, neurologic disorder, unable to eat, etc., then most individuals will increase that total treatment up to 21 days. So that is how we deal with a classic congenital syphilis. There are, as you can imagine, a whole bunch of ifs, ands, or buts when it comes into interpreting mom's therapy. For example, she was treated, but her RPR has not become negative. It's still perhaps low positive. Is she still infected? Did she maybe get reinfected? And in cases where it's unclear, it's quite reasonable to give baby a single intramuscular dose of benzathine penicillin, also at 50,000 units per kilogram, as a single dose, and then follow the baby's RPR every 2 months until it's negative. If it's increasing after birth, then we actually needed to have done the full evaluation, the full treatment, but most often that is not the case. And that single intramuscular dose of penicillin would be adequate for those cases which were probably okay, but we don't know for 100% sure. So there you go. That is sort of treatment, both assessment and treatment of congenital syphilis. This is a talk about infection prevention. And of course, recognizing and treating infection is a way to sort of prevent it from escalating. And I realize that. But also, as I started off with that at the beginning of the podcast, this is an area of medicine that can and should be preventable by effective screening of the mothers. Also, by getting both mothers and fathers into awareness, being through diagnosis. As you can imagine, and this gets now into social determinants of health, a large majority of the mother-baby congenital syphilis dyads or pairs that we have, certainly in Arizona and elsewhere as well, come from a social demographic that has very limited or poor access to health care. And the typical phenotype of the mother is somebody who herself is experiencing many challenges, perhaps substance abuse or polysubstance abuse, experiencing homelessness, experiencing domestic violence, experiencing no or limited prenatal care. So those are mothers who may not be picked up because they're not presenting for their syphilis screening. Similarly, again, takes two to tango, so there are men out there who, of course, are a significant repository of untreated latent syphilis, which is just as contagious, and if they're not being routinely screened, then, of course, they're not going to be picked up either. And, obviously, it's not going to be the fathers undergoing prenatal screening for syphilis. So, a current approach in Arizona, and hopefully elsewhere if you're tuning in from outside of Arizona, is that every adult of sexually active age who presents to an emergency department in the state should be screened with either a screening treponemal antibody or a screening RPR, and if positive, they should be treated with a single intramuscular dose of long-acting benzathine penicillin. That would be the treatment for men and women in the case where mothers are not pregnant. If mother's pregnant, then she gets additional doses. So that is a way to try and prevent infection to the baby by detecting, recognizing, then treating the adults who are contributing to infected mothers who then are transmitting disease to their babies. And that is the most effective way currently known to prevent, I should say, congenital syphilis from occurring. It would be also wonderful if we were able to increase access to health care for those women who are experiencing significant barriers to health care and social distancing. But that is also a complex issue which requires a lot of resources, and certainly mobile healthcare vans that can screen and test is one way. Screening at large social events, partnering with local, county, tribal health departments to increase screening. All these are actively being worked on as I speak, but yet still the large majority of women are those who will somehow slip through the cracks and escape all of those. So one word, I suppose, in terms of infection prevention in the clinic setting, if one has a baby just born to mother with known untreated syphilis, so we already have a known risk to baby of congenital syphilis, baby should be considered potentially contagious until they've had their first bathing event. If they have active skin lesions, that desquamatory skin rash which I discussed from the palms and soles, those lesions might be contagious with treponema until baby's been treated at least for several days. So contact precautions, meaning gowns and gloves, good hand washing, of course, before baby, but certainly afterward are going to be appropriate. Syphilis is not known to be transmitted via a respiratory droplet or airborne transmission, so masks are not necessary. After baby has been treated, and while we're following their RPR to make sure it turns to negative, there is no need for infection prevention or barrier steps in the clinical practice at all. So again, most of the infection prevention steps having to do with congenital syphilis are very much related to preventing the transmission in the first place to those babies. So there you go. That's a rapid primer on congenital syphilis, both what the risks are, what it looks like, what we do about it, how we recognize it, and sort of an earnest bid at very much the sort of upper level public health epidemiologic level to try and prevent disease transmission to that baby. Yeah, okay. Certainly there is plenty out there. The Arizona chapter of the AAP has hosted a recent webinar which discussed this issue as well as perinatal hepatitis C, which is the next component of this infection prevention mini-series podcast. And as always, I encourage you to tune in to both the chapter's website as well as the CDC, the AAP, all which have resources for physicians and also for families to help provide information and knowledge about this. And perhaps the very one most important and last word to leave you with for infection prevention is to think about it, and if you think about it, then you can prevent it. So thank you again for tuning in to this Project First Line mini-series podcast on infection prevention. This will be the end of session 1, and tune into session number 2 to hear about perinatal hepatitis C virus transmission and infection prevention as well. Thanks again for tuning in.